I have a nice video and I'll show you. And this is a case, same thing. These are called Carotid Terminus clots, right behind your eye, so it doesn't supply the whole hemisphere. These are deadly strokes. I mean, if you don't open it up, the patient's going to die. And within probably 7 minutes, we had this open. 5 to 10 minutes. It's very fast. You go up there, you just keep on going and aspirating, and it's just sucking everything into the catheter. Then we have the Solitaire Device, and basically it's a retrievable stent. It was made to do aneurysm treatments, and that you could retrieve the stent later, so you don't have to leave it in the body. And they found out it treats stroke, and they market it, and it does an amazing job. This is an example of a middle cerebral artery occlusion. This patient, it's the right MCA, so patient has left arm weakness, left leg weakness, left facial droop. And, you know, the picture on the right, after 2 passes, literally 10 minutes, it's open, patient's moving on the table. And that's a picture of the stent with the clot on it that was trapped. Now I have some videos for you. So I'll show you penumbra first. So basically, this is supposed to be a carotid that goes up, and then the one going to the 10 o'clock position is the anterior cerebral, supplies your leg, and that's the middle cerebral. Basically, we take a wire, and we take our catheter up, and we try to kiss the clot. And then we just take our separator wire, and we go in and out, and then we turn the aspiration on. Now, the aspiration, the reason it's not always on is because it's very loud. The machine is extremely loud. But the second generation device is much quieter, because I told them if it doesn't, I expect it to make me cappuccino. So, and it really does move this quickly. I mean, you're just going in and out, and as you see the blood coming back in your catheter, you just advance the catheter. You just keep going forward and break it up, and you suck it all in.
All in the cath lab, right?
This is all in the cath lab. Under fluoro. So these all have fluoroscopic markers. So I'm watching under live x-ray. Now the other device is a little bit more interesting. So this is the Solitaire Device. And with this one, we're going to put a balloon catheter in the neck. And basically, we're going to want to suspend blood flow going north. And then we take the wire, and this time, instead of pushing the catheter to kiss the clot, we actually have to go through the clot. So we go past the clot with the wire, and then we advance the microcatheter past that clot. And this is what they're animating right now. So once we get past the clot, we pull the wire, and then we advance the actual Solitaire Device. And once you advance the Solitaire Device, it kind of unsheaths like a stent. And you'll see, he'll be doing it hopefully. So now he's advancing the stent, the Solitaire Device, and then you kind of unsheath it. You basically pull back the microcatheter. And the whole point of doing this is so that it's safe, so it doesn't damage the blood vessel. Once you unsheath it, the nice thing about it is you get immediate temporary antegrade flow. You're getting blood flow to that part of the brain that was going to be completely dead if it didn't get oxygen. And we usually sit about 5 to 7 minutes, let it really sink its teeth into the clot, and then we pull it back. So in this case, you're gonna lock it. He's going through the details, but you don't need to know the really details. We inflate the balloon at the neck so that you don't get any blood flow going north. And then we pull it down. And the nice thing about it is, remember, where's the stent? It's within the clot. Whereas the Mercy device was past the clot, sitting at the blood vessel and pulling back. And that's why you used to tear blood vessels. So again, remember those original numbers. In the US, we're only treating about 3.5% of patients with IV TPA across the country. And we're only treating a little bit more than 0.5% with endovascular. Now, if you look at the numbers from the University of Minnesota, the group I trained with, they started there around 2006. So the first full year they were there was 2007. And they analyzed the data for 4 years. And they saw that basically their stroke volume doubled. their percent of IV TPA patients was about 10%. So they were treating 10% of their patients with IV TPA. Then they get another 4% via drip and ship. Patients that at rural hospitals would get started with IV TPA, whether it's Brownsville, Valley Regional, McAllen, whatever it is, and it comes then to them. And they take the patient either to endovascular or admit to the ICU. Then if you add the endovascular patients, it's another 10%. So by the end of the day, they're treating 23% of the strokes that come in through their doors. That's a big number. If I can treat a quarter of strokes, that's how many lives you're saving. So some of the conclusions: time is brain. IV TPA is the only FDA-approved medication for treatment. Even though it's only FDA-approved for 0 to 3 hours, we can give it up to 4.5 hours. But you need to get to a primary stroke center. Valley Baptist Brownsville, Valley Baptist Harlingen, we're primary stroke centers. Nobody else in Cameron County is a primary stroke center. Endovascular interventions can be of benefit in selected patients in specialized centers. So we can treat those posterior circulations. You don't want to, you don't want your family member to die of a brainstem stroke. You don't want someone who woke up with a stroke not to be treated at all. So those are the types of patients we can do something additional for. The availability of endovascular should not preclude IV. And basically, that's why we have that protocol the way it's set up. If the patient's IV TPA candidate, they go through all the steps, they get IV TPA. Then they discuss whether or not the patient should get endovascular. Then there's obviously room for improvement. Public awareness is number one. I expect everybody today to tell at least 2 or 3 people, family members, friends, cousins, whatever you want. If you have face weakness, facial droop, arm weakness, leg weakness, any slurred speech, immediately call 911. Tell them to take you to the closest primary stroke center. And then we're obviously working on making our protocols better. We're working with the state. We're working with the American Heart Association. And we're continuing to research. We actually have the first NINDS trial in the Rio Grande Valley we're doing here. We have multiple NIH-funded trials here. So we're really creating that academic atmosphere to bring you level 1 research. Thank you very much. Questions?
Question. Have you ever heard of anyone having a stroke while they were getting a pacemaker procedure?
Yes.
What would cause that?
What would cause it? Well, you can have a stroke at any time, but when you're getting a pacemaker, basically you have some wires, some tubes in blood vessels. So anytime you have a foreign body in a blood vessel, you're more likely to clot.
The doctor didn't know what the cause was, and he got it inside his realer and left the lane.
It's not common, I'll tell you that. It's not very common. But you can have a stroke at any time. I mean, it could have just, he was going to have a stroke whether he was on the pacemaker or not. But it's not a common occurrence. Yes?
I've been advised that if you think you're having a stroke, you should take a couple of aspirin and chew it. Is that a reasonable thing to do?
Never. That's a good question, actually. Thank you for bringing it up. Never take aspirin, because you could be having a bleed. Remember, 87% are clots, but 13% are bleeds. And if you take aspirin and you bled, you basically signed your death certificate. Yes?
Can you help anybody that had a stroke 12 years ago?
I'm sorry? Well, no. I have 17 years? No. Unfortunately, rehab is the only thing that can help. But you can at least make sure that you have secondary prevention. Making sure you don't get another stroke, which could, be the end. So that's why you should always see a neurologist and make sure you're seeing your cardiologist. And
The thing was, the hospital I went to, there was no doctor to give me the shot.
Mm-hmm. Well, thankfully now there's a couple of primary stroke centers throughout the valley. But you proved my point. Remember, we were saying that in the beginning. Rural areas are completely underserved. Any other questions?
If you know someone that's had a heat stroke, say about a
I can hear it, that's fine.
if you know someone that's had a heat stroke about a year and a half ago, they can still be treated?
A heat stroke? So heat stroke's a completely different animal. It's more because it's a mixture of dehydration and electrolyte disturbances. But they're more likely to get it again, so they should see a physician. But are they weak from it, or do they have symptoms from it?
Well, that person's still alive, but they had a heat stroke about a year and a half ago. I'm wondering if they can still get treated. Or is it too late when they do like a permanent disability?
Well, that's what I'm asking. So the patient does have disability now? Yeah, no. Usually, so the brain gives you about 6 to 8 hours to treat a blood clot. And in the posterior circulation, you can treat up to 24 hours. But outside of that, you can't treat them with anything. You can just do supportive care and rehab to try to get them better.
Before you were here, how did they treat the patients?
Well, they were giving them the IV TPA. Dr. Parada in the emergency room would give IV TPA. But yeah, you would only be treated up to 4 hours. If you came into the hospital after 4 hours, you were not getting treated.
My wife had one, and after about maybe 8 or 10 hours, is there anything I can do? I mean, after 12 hours or 8 hours?
After 8 hours, well, surviving is a different question. So remember, out of the approximate 800,000 strokes, 130,000 of them die. So that's the ratio of deaths. So it doesn't matter whether they stroked and you treated them within 1 hour, or they stroke and you don't treat them at all, 1 hour, 10 hours, 2 days. It doesn't really change the outcome. But nowadays, if you came in after the IVTPA time window, we could do CT perfusion. So if we find any salvageable tissue, we'll go in there and pull the clot out. Yes?
Are you on staff here full-time?
Yes.
About approximately how many people do you treat a week?
I've been here for 9 months, and we've treated 350 patients so far. Not all strokes. There have been other things too. No. If it's a TIA, it means it's resolved by the time the patient comes in the ER. If the symptoms are still there, then we're going to treat them. And we actually have a couple of trials set up for TIA patients for newer treatments. Yes? No, we're the only comprehensive stroke center in the whole valley. Yes, they have a primary stroke center. So if you think you're having a stroke, you should go there first, because it could be a bleed, it could be something else. They could give you IVTPA much faster than waiting to come all the way over here. But then if it's a large stroke, they'll transfer you over here. Where is what? Oh, who's the primary stroke center? I think McAllen Medical Center is the primary stroke center.
No, we're taking to the nearest place, to the nearest hospital.
Yes, take you to the nearest hospital. I'm sorry, sir. What?
Is the substance of the clot identifiable?
Is the substance of the clot identifiable? Most of the time we don't identify it, but it's usually between lipids and fibrin split products, blood products that break up via platelets and stuff like that.
It would be platelets, or would it be something other?
Oh, it could be a number of things, but majority are platelets. Thank you very much.